TibFib protocol for us is an AP and lateral. You're going to use your 14-17 cassette or imaging plate corner to corner to try and get more length for you. Hopefully you can get the patient on in one image, otherwise you have to split into two. Always include both joints. So unlike this picture here where they're going straight on, you want to go corner to corner ideally. So place the leg in true AP position, foot dorsiflexed. You're just going to center the midpoint of the leg. Just like lab, where I taught you, I want you to look at the shadow of the lateral malleolus. That will really be key in making sure you don't clip off the ankle. You can increase the distance from 40 up to 48 inches, but if you increase the distance, I want you to make sure and increase your technique a little bit too. Ideally, you have both joints on here. So the top of the tibia here and all the way down to the lateral malleolus of the fibula. Medial-lateral, so turning them on their side with a little bit of bend in the knee. Again, shadows are key for this. Look at the knee shadow, make sure it's within your cassette and not on the outside border. And check for the lateral malleolus. Make sure it's on the imaging plate. Similar to that of lateral ankle, you want to make sure they're superimposed. So ideal here, lateral knee down to lateral ankle. Okay. For us, if the child is 4 years old and under, we include a medial oblique TibFib for pediatrics, specifically looking for a toddler fracture. It's a spiral or oblique non-displaced fracture, which means it's sort of hard to see sometimes. So we will do a straight AP as normal, a medial oblique similar to that of the Mortise ankle, but including all of the TibFib, and a lateral. They're usually resulting from a twisting injury. Knee routines. There's a couple knee options for us at the clinical site, at the main site, and specialty views are often done at the off sites. So we're going to go through all of these. Our normal protocol for patients up at the main house here for a 2-view knee is an AP standing and lateral recumbent. If the order specifies 3 views, you're going to include the sunrise patella view. If you're in the ER or the patient states they had trauma to the knee, you're going to do a supine AP and a cross table lateral. If you have a pediatric patient that are 18 years older, younger, you are going to do them supine AP and recumbent lateral. If the order specifies bilateral knees, we do them standing bilaterally on the same image. All right, but I'm going to take you through all of them. So, AP knee. If there is trauma, you'll be doing it supine on the table. All right. Central ray, 1/2 inch distal to the apex of the patella, 10 by 12 cassette lengthwise, 40-inch SID. All right. If they are not trauma and they're here just for pain, our protocol is to do a standing knee. So you'll detent to the wall stand. You'll bring this into 40 inches, and like they have here. All right. Same centering. Okay, you want to see a nice open joint space. Make sure the patient's not rotated. Ideally here, go through your anatomy. This is what it should look like here. Your textbook identifies some angles for the AP. At your clinical site, the technologists don't tend to follow this, or it's gone by the wayside. So what I want you to realize, though, is for your patients that are between 19 and 24 centimeters at the knee, you can shoot straight. If they're below that size, your textbook tells you you're supposed to do a 5-degree caudate angle. If they are larger, 25 and above, 5 degrees cephalad. This is in all the board reviews books, and it will be on my test. So identify those numbers. So 19 to 24, you're shooting straight. 25, they've got some junk in the trunk, so the butt is raised up, so it's at an angle. So you're going to angle up. All right. 18 and under, they don't have much of a butt. They've got kind of a pancake butt here. You're going to angle down. Recumbent lateral. You are going to do the table bucky. Put them in lateral position. I would like this leg up and over in the front, and I'll show you why in lab it makes it easier to find your lateral position. Central ray is 1 inch distal to the medial epicondyle. You need a 20 to 30 degree bend in the knee. Watch for the hips. Watch that they don't over-rotate. Feel straight on for that patella. This is what it should look like. Your femoral condyles should be superimposed over each other, and there should be space between the patella and the femur. Why do we angle for lateral knee? The medial condyle on almost everyone is usually lower than the lateral condyle. So we angle to put them on the same plane to superimpose them. Tramanese. For ER patients, we do Tramanese, and for any patient that walks in with a history of trauma, they were in a car accident 2 days ago and they're here for knee pain, we do the trauma series. So the trauma's knees are supine AP and a cross table lateral. We do that looking for some air fluid levels. So for the ER patients, you're going to want to place a sponge underneath their leg, raising them up off the stretcher, and the cassette will go in the inside of their knee here. You're going to do lateral medial instead of medial lateral on those. You may need to utilize tape to keep the cassette in place. We tend to do non-grid unless the patient's knee is very large, and then you can add a grid, but the ER, you can go non-grid most of the time. If you're going to angle on this, you're going to angle down instead of up, because now we're going lateral medial instead of medial lateral. Or you adjust the leg in medially, and we can show you that on the stretcher. Again, you want superimposed femoral condyles, open patellofemoral joint space. How to look for it. All right, so the condyles should line up, and they identified clearly here with these lines that they aren't completely superimposed. This one's not perfect. Okay, there's a small amount of rotation. This is a little bit pointed out for the fibula. Okay, let's say this knee comes up. It won't, because all of yours are going to be perfect. But just say that this happens. All right. How do you figure out which way to move the patient? How do you know which way they're rotated? Is that knee too far away from the table? Or is that knee too close to the table and the heel is raised up? I look for the relationship between the tibia and the fibula. So if you put your knee in lateral position for me, feel on the outside for your fibula. When you pull your knee away from that imaginary table, which way does your fibula go? It moves into the tibia. If you push your knee towards the table, raising your heel up, the fibula is going to move behind the tibia. So I know that this patient is too far away from the table. They need to rotate down towards the table to superimpose these condyles. Here's a little cheat sheet for you as well. When the fibula is pushed back, this is over-rotated. They're rotated too far towards the table. And then when the fibula is kind of sitting underneath the tibia, under-rotated. How do we fix this? This one is both angulation and rotation. So can you see how these are separated up and down? They need more cephalad tube angle. They're also rotated forward back. They needed a little bit more rotation. So tube angle and rotation. This is a cross table lateral. Even when it's cross table, I still look to this relationship. So this is both angulation and rotation. Why? They're separated up and down and forward back. Weight bearing. They might order AP weight bearing bilateral. So what you're going to do is stand the patient AP 14 by 17 crosswise. Do not photo time because the cell is going to be in between the legs. All right. We're looking for narrowing of the joint space and possible varus or valgus deformities. So it's either varus is out or knock knees, valgus is in. You want to see both knees, and then you do this. Laterals will be separate. This is kind of some crushed joint space here and open joint space there. Obliques. We don't often do knee obliques at our site, but maybe the off-sites will do them, and they are in your textbook. It's a 45-degree medial rotation, and central ray is the same. Okay, it's either medial or lateral obliques, and this is what they'll look like. You can see the patella shifts with it. Sunrise for patella, this is the one we use most often at our clinical site, where the patient's knee is bent with a tube angle and the cassette is held here. Usually it's an 8x10, or if you're in the digital areas, it's that big cassette, and you'll just collimate in. Looking for kind of an open space here. The patella is going to sit on top. Kind of looks like a sunrise, if you will. If you overflex the knee, can you see where these are superimposed now? So too much of a bend actually closes it. So don't go too crazy. Your textbook identifies a lateral patella by itself. We do not do this routinely at our site, but it is in your textbook. So just kind of a collimated, tightly lateral knee, if you will. All right. Merchant view is a bilateral patella method. We do not have this set up at our site. But maybe some of the orthopedic offices do. 40-degree knee flexion, central ray angled 30 degrees from horizontal. This is the Hobbs modification, which is a sitting. Can you see how she's sitting in the chair and the cassette is below her? The tube is in front of her here coming down. This is kind of from the top view, and you can see the shadows of her knees here. This is what the Hobbs modification would look like. Camp Coventry method is a PA axial projection. We call this a tunnel view. The patient is prone. The lower leg is flexed 40 to 50 degrees, and the central ray is perpendicular to the lower leg. You'll see we're looking for the intercondylar fossa in this tunnel. It kind of looks like a tunnel right here in the picture. So if your image looks like this, that's your tunnel view. The Homblad method is another version of the tunnel view. It's the patient's on their knees, leaning forward 20 to 30 degrees. You can do it in a chair or a wheelchair. And this AP axial method, I believe, is the Bilateral method. So if you need to do a tunnel view but the patient can't go prone, there'll be AP, the cassette supported, knee flex 40 to 45 degrees, same centering, CR perpendicular to the lower leg. That is the Bilateral. Here's the Bilateral method. You can see it looks like a tunnel in here. Pediatric knees are done supine. You can identify that these are pediatric knees by the epiphyseal growth plates that are still open. Know your knee anatomy. I'm going to flip through here. I don't think I have any more. Okay, I'm going to skip that there.